So it's excellent to welcome Pat McKiernan for Birmingham, who's a paediatrician with huge experience in liver disease, and he's taken a particular interest in the use of liver transplantation in this condition. So Pat, welcome, and thank you very much for coming.
Thank you very much. And this is a very different area for me. As Tim says, I'm a liver doctor, and really kidney medicine is not my strength, and certainly my kidney colleagues definitely tell me that. But one of the privileges I have is learning, and one of the great enjoyments of our work is that we learn new things, and we learn from new experiences, and our families and patients come along with different dilemmas, and each year we have different decisions to make. And so I guess for most of you, liver transplantation is a foreign area. So I wanted to explain a little bit about the history of liver transplantation, using liver transplantation to treat non-liver diseases, and then to talk about liver transplantation in the particular issue of atypical hemolytic uremic syndrome. And then I think I will ask a real expert to talk about somebody who's had a liver and kidney transplant for this disease. So liver transplantation has a history of less than 50 years. It was developed in Denver by an unusual individual called Professor Starzl, who's still alive, and he's a very, 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 very single-minded individual. And liver transplantation, when it was first tried, wasn't successful. And the second time it was tried, it wasn't successful. And the third time it was tried, it wasn't successful. But eventually, it was successful. And one of the things we should learn from that is not that we should be cavalier. We clearly do need to learn from experiences. But also, in our very regulated environment, if this had been in the 2000s, liver transplantation might never have got off the ground. So I think we have to be balanced. We must not be cavalier, but we must always be prepared to learn new experiences. And eventually there were sea changes. The drug cyclosporin completely changed this. There was the concept of brainstem death was allowed so that organs could be retrieved from people who had died while their heart was still beating, that allowed liver and kidney transplantation to become extraordinarily successful. And the first pediatric liver transplantation in the United Kingdom was carried out in 1983, I think. And in 1987, a big number of technical developments happened. This is results for liver transplantation from our centre, and this is survival along this axis, and this is time. And I think that you can see clearly, in the early stages of liver transplantation, it wasn't so good. Now, it's a much more successful transplantation. And we would confidently be able to ask somebody who's coming as a child to have a liver transplantation that they have a greater than 90% chance of being well in a year's time, and that the vast majority of children who undergo liver transplantation will reach adult life and things. So it's become an extraordinarily successful treatment. I think one of the other things to say that the risks for transplantation are in the early stages. And the people who survive and do well in the early stages after transplantation continue to do very well in the long run, which is a very important part of the rationale for liver transplantation. I don't want to overdo it, and I'm not a surgeon, I'm a physician, but this is complex surgery. There's 3 operations involved, essentially. The person's liver has to be removed. The donor, who's usually somebody who's died, but it also can be a living person who's giving part of their liver to somebody else. That operation has to be carried out, and then the new liver has to be put in to that person. So it's complex surgery, which is why there's a risk. The liver, as I say, has to be removed. This has become very successful in pediatric transplantation because thankfully the donors from which livers come are usually adults or older children, but children can have successful liver transplantations because livers can be divided, can be cut down in size, or actually what is much more successful is that the liver can be split in 2 so that from an adult can have that, can benefit from this liver transplantation, and a child can benefit from this liver transplantation. And also, living transplantation can come that part of the liver can be removed from a parent usually, or a grandparent or a relative, to give, to allow a child to have a successful life with transplantation. Now, I say, this is the reasons that we do liver transplantation in Birmingham for the last 5 years, and most of the reasons that we do this are because children have a fatal liver condition. And the decision is frankly not difficult. They have a nasty, unpleasant liver condition. We have a treatment for that works. This is a no-brainer for the great majority of people. You know, things. something like biliary atresia or end-stage liver disease. They're fatal without it, and it's a very successful treatment. But increasingly, there are a number of other conditions where metabolic liver disease and where we carry out liver and kidney transplantation, where the decisions are rather different, and that's what I talk about. Sorry, this is referring to our indications for liver transplantation where you've got liver disease. And frankly, that, as I said, that's relatively easy. Families know how sick their kids are, and they know they can see from when they come up to outpatients how well the children are after liver transplantation. And this isn't difficult. Where it does become difficult is when we move into other indications for liver transplantation. The liver is a very complex organ, and it carries out a number of genetic and metabolic processes within the liver. And when you have a liver transplantation, the genetic processes that happen in that liver are then transplanted to you. So if you've got an abnormality of complement metabolism in your liver, and you receive somebody else's liver, then your complement disorder is cured. It's gone away, because you've got the complement production of whoever gave you that liver in the first place. And you've got a complete correction of that disease if it's made within the liver. So when there are a group of metabolic conditions where we carry out liver transplantation, and the consideration is, if it causes liver disease, well, then it's a relatively easy decision. But when the metabolic disease is in the liver but not causing liver disease, it's a much, much more difficult decision. And we have a number of examples of this, and one of these are the factor H deficiency and the factor I deficiencies causing hemolytic uremic syndrome. And what we know is that if we do liver transplantation for metabolic conditions, again, the same survival curve, there's a risk in the early post-transplant period, but subsequent people who survive this will become long-term survivors. The vast majority will survive into middle age, and they will be cured of their disease, and they will have long-term cure of their disease. If it's expressed in their liver, it will not come back again. So it's a very effective long-term treatment, but carries a risk at the time of surgery, and also carries the risk of needing lifelong immune suppression currently. So you've got a different set of indications to consider as a family, and there are choices to make. It depends how good we are at doing transplantation. It depends what the prognosis for the metabolic disease is. And of course, that might not say the same. So the conditions we transplanted for 10 years ago are quite different than now, because a new treatment for the disease may have come along that make transplantation irrelevant things. So this is not fixed in stone and may change with time, but all you can do is make decisions with the information you have available to you at that time. And you have to look at, how is our current treatment? Is it effective? Is there a new drug on the horizon that's going to come? How does it affect us? Do they need dialysis? Do they need plasma exchange? How well do they tolerate it? Can they go to school with it? Is the lines causing difficulty? Do they get pulled out when they're playing PE, etc., etc.? Another thing is, of course, that we sometimes have to make the decision is, the disease is not causing a problem at the minute, but there's a potential of causing end-stage renal disease, or we might have a metabolic disease that can cause brain damage. And in that situation, you want to do the transplantation before the damage has occurred. So you want to be doing the transplant before they're in kidney failure. You want to do the transplant before they've got brain damage, etc. Because you want to prevent disease where possible. So there's a different set of decisions to be made and discussions to be had with family in this situation. I'd just like to mention as well liver and kidney transplantation. Liver and kidney transplantation is a non-common operation in childhood, and I think we're in a very unique position in Birmingham, because we have a liver and a children's renal transplant centre in the same building, and we've undertaken 33 liver and kidney transplantations, and only one of which is for atypical hemolytic uremic syndrome. And as I say, follow-up is relatively long-term, but still quite short in children who we hope are going to live a long life. But it's a very successful treatment. One other also thing to take into account is that if you do a liver and kidney transplantation, there's something in the liver transplant that protects the kidney. And there's no doubt that if you have a liver and kidney transplantation at the same time, that the risk of getting rejection in this kidney is much diminished. And rejection has hardly occurred in any of those children renal rejection has hardly ever occurred in those who've had liver and kidney transplantation. So that's a factor to be taken into account in this very complex and difficult decision. So when you're weighing things up, there's no doubt that if somebody's coming to kidney transplantation or liver and kidney transplant, a much bigger operation, riskier operation around the time of transplant. The drugs you have to take for the rest of your life are the same, whether you have a kidney or a liver. But you probably get a better kidney survival if you have a liver kidney transplantation. So advantages and disadvantages in a very difficult weighing up procedure. Now, then we come on to what I'm really meant to be here to talk about, the atypical hemolytic uremic syndrome or complex factor deficiency. And you've heard about this, and you guys know this a lot better than I do. And you know that, of course, renal transplantation can be difficult in some of the diseases because it comes back again, etc. So we know these complement factors are produced in the liver. We have lots of models that doing liver transplantation is a very effective way of treating these diseases. And so people try to do it. And I have to say, the first times they tried it was a disaster. I think, and again, this is a recurring theme. I think our current strengths are based on experiences and mistakes from the past. But we're in the position now of learning from those, and we've all benefited from what's passed before. The first child who had this, unfortunately, the new liver didn't work, and the child became extraordinarily unwell and suffered brain damage as a result of the illness after liver transplantation, and then had a second liver transplantation, and in fact remained free of atypical hemolytic uremic syndrome, but unfortunately died 4 years later as a result of the damage that had occurred at the time of the transplant. And the first 3 transplantations for this were, for various similar reasons, a disaster for the children. But, so I won't go through them all, things. But so I think we learned that it is true that liver transplantation will correct the atypical hemolytic uremic syndrome in these defined cases. But doing the transplantation itself is a high-risk procedure, and you actually start complement activation, etc. And liver transplantation is a very good way to get complement activated. So clearly you need to do something different. Things. And then the very bright idea, and this is where you need teams of people to work with, that if we do a very active plasma exchange so that you've got normal factor H levels at the time you go into liver transplantation, it will be better. And the first case of this was in North America in Mount Sinai Hospital. And again, it worked. Do the exchange first, and the child had a previous kidney transplantation. He had pre-operative plasma exchange, and now he's 8 years post-liver and kidney transplant, and he has not had recurrence of his disease. So that was a step mark to say this is a feasible thing to do. My first experience of this in our centre was a young man who had atypical hemolytic uremic syndrome, was started on plasmapheresis, and he had renal impairment, but not renal failure. And he came to us for liver transplantation because he was running out of vascular access. There was nowhere to put the line for the plasma exchange, and he was getting venous narrowing. So he came to us for consideration of liver transplantation before he got end-stage renal disease, but needed plasma exchange. And he underwent liver transplantation at age 4, and he had the pre-operative plasma exchange. And really, since he's had no recurrence of his disease since that time. His renal function is well preserved. He's got his normal platelet count. He's now 3 years post-transplant. His kidney function is not normal, but it hasn't deteriorated since transplantation. And he has had no episodes of atypical, he's had no relapses of his hemolytic uremic syndrome. We've also had one child then who presented with end-stage renal disease, and he then, after discussion of the various options, underwent a liver and kidney transplant last November. And again, he went home on day 18. He had some technical problems afterwards, but he's 7 months afterwards. And he's on 3 drugs. He's got normal liver and kidney function, and he has no more hemolytic uremic syndrome anymore. Thanks. So overall, this approach has been very effective, and we know, and Tim may know of other cases here in this, but 15, 16, 17 cases have been done in this regard. And this has managed the difficulty of the hemolytic uremic syndrome, the flare in this at the time of transplantation. But, you know, we mustn't get blasé about it, but there's still a risk of death. And 2 of the children who underwent this died for transplantation, probably in retrospect due to technical factors, which I think have been things. But so you know, it's not a panacea, but we have learned a great deal from this. So I think I just want to say there are options now, and I think this is a situation where we have a disease in which the outcome for is much improved. We have good and improving medical treatments, and you're going to hear about some of these. So the choices are getting better all the time. But people do have choices as to what to do, and I think these are choices that families and people need to make. Doctors' roles here are to inform them and help to guide them, but it comes down to the families themselves and the parents to take the responsibility to make the best decision for their family with the knowledge they get from the professionals that support them. So there are options. You can keep on dialysis, you can a kidney transplant. I don't think anybody would suggest that's a sensible thing to do in this day and age, but you can have a kidney transplant plus something else, or you can have a combined liver and kidney transplant. And I just put, you know, again, this balance. If you have a liver and kidney transplant, the risk of the time of operation is higher. But the drugs you take for the rest of your life are the same. So the renal graft will probably last longer, and you cure the disease. You don't have to take any treatment. So I think this is a very successful treatment that for some patients and some families will be the treatment, but it needs to be considered as an option that's over to families. Now, I think I know a little about liver transplantation with this, but I think I'm just going to ask John to come up and speak because he knows a lot more about it because he's actually had a liver and kidney transplantation for this disorder. So John, are you happy to come up here now and join me? Okay, John. So, would you like to tell everybody how you spent your 60th birthday?
Well, I was, sorry, I was at work, and on my 60th birthday, I decided to take a week off, and I developed a stinking, rotten headache, and it lasted till Monday, so I went to the doctors, and they took blood. And he didn't give us anything. He just, if it comes back, or if it gets worse, come back. So I did. Took another lot of blood. And on the Saturday morning, I was a knock on the door. The doctor, you've got to get into hospital quick. You've had kidney failure. And that was my 60th birthday. And from then on, dialysis for 3 years, and I was put on a transplant list, and 2 years ago I had the kidney and the liver transplant. And ever since I've been fine.
Thank you, John. And how many drugs are you taking now, or have you lost count of how many?
I take about 18 to 20 a day.
Okay, that's a lot of medicines. And how this is probably your thing. How does your life compare to, pre-transplant? What's the big difference?
Well, I've got 3 days back in my life, and because you couldn't plan anything until I had the transplant, and now I'm free to do what I like. I've got clinics now and then, but they're just keeping a check on us, which I'm very grateful.
Yeah. No, I think, as you can see, John's looks in good shape. He's not actually feeling very well today, but he's expressed himself very well. And I think this is exactly the balance. I think he had an option to stay on dialysis, to go for other treatment, and he took maybe the slightly more risky treatment. But the other side of that is you can see that afterwards, it's just oral treatment that you need to take. And the future for somebody like him now is very, very bright indeed. And he has essentially been cured from hemolytic, because that liver that he has doesn't have factor H anymore. And that really changes things. Thank you, John.
Thank you.
So I think that's all I had to say, because I think he says it better than me.
Super. Well, thank you. Any questions? Oh, Pat.
With the liver transplant, because my daughter's got a factor H and a factor I problem, would a liver transplant actually solve both? Or because you refer to it really as a liver transplant for factor H?
Yes, I think because factor H is the commoner, it would also cure factor I deficiency in the same way. Now, obviously, the other disorders is a little more complex, we're much more likely to be expressed and things. But factor I and for factor H, it's very clear. They're expressed, and the great majority of synthesis dose is done within the liver. So the liver you get doesn't have those deficiencies anymore.
Brilliant. That's fine. Thank you.
Hello, I've got atypical factor H, and I was told that I can't have another transplant because it recurred in my last transplant. Would I be able to have the liver and kidney transplant then if mine is factor H, and how would I go about it, going on the list for that?
Are you factor H?
Yes.
It's certainly an option. Obviously, I don't know you and I don't know your individual medical history, but absolutely, in theory, that's possible. And this is one thing for sure. I think after a liver and kidney transplantation in that situation, you would not get recurrence of the disease.
Right.
Now, whether the suitability for a liver transplantation is a different issue, because not everybody is suitable for a liver transplantation. But from here, you look quite young, so I would imagine. Thanks. I can't see that far. I was thinking, but in general, I have to say, young people will generally be fit to undergo a liver transplantation. But obviously, there's a complex assessment procedure to go through, because there are some people who won't be fit.
Yeah.
But you have a very good chance of being fit.
So I would just ask my consultant about it, would I?
Yeah, I think this is certainly an option to consider. I think and as I say, your consultant who knows you, there may be some other factor that interplays that he or she knows about.
Yeah.
But in principle, I think if you've had a kidney transplant that's already failed.
Yeah.
That's an option. But of course, you'll hear there's another option as well coming along. So you're in the time of, I think it's win-win for patients who have atypical hemolytic uremic syndrome, because there's developments on both sides.
Right.
Transplantation is better, but the alternatives are also better as well.
Yeah, because I think it was the immunosuppressants as well which didn't help. So.
Yeah. Because I think that's one of the things, because the immune suppression after liver and kidney transplant is no different than that after kidney transplantation alone. I think. So if you're going to have a transplant, you're going to have to take immunosuppression, but it's no different whether you get it.
Okay, thank you.
Any more questions for Pat? If not, thanks very much indeed, Pat. It's great.